Right, ladies and gentlemen, the last of the 5 papers to be presented is on the concept of medical rapid deployment force, sharpening the leading edge of healthcare provision. And it will be presented by Dr. Munasingha, who's had his education at Anand College, Colombo. He passed MBBS in Sri Lanka in 1990, MD in Colombo 1997, is a fellow of the American College of Physicians in 2010, Master of Artificial Ventilation, University of Sorbonne, Paris, that's in France, member of the Society of Critical Care Medicine, USA, member of the European Society of Intensive Care Medicine, President Critical Care Forum of Sri Lanka, and we were awarded the Indian Society of Critical Care Medicine for pioneering critical care in Sri Lanka. He is presently the consultant physician, Victoria, Sri Lanka, Emergency and Trauma Care Unit, Teaching Hospital, Karapitia. I would now request Dr. Munasingha to present his paper. Thank you.
Thank you, Chairman, ladies and gentlemen, and senior medical officers and army officers here. The concept of medical rapid deployment force. It's my experience as a physician at the Ampara General Hospital during the war. I have been working as a physician in charge of the medical intensive care unit and the physician in charge of the medical department for 4 years during the war. So we'll see what medical rapid deployment force is. I'm actually presenting this along with my colleague, Colonel Senivaratna, who is in the audience. Now, the concept of rapid deployment force is not a new thing. It was introduced by the USA, as I have mentioned here. The following report published by the Research and Development Corporation in 1979. This report was intended to break post-Vietnam War problems, as I have indicated here. Later on, this concept was broadened and branched over the years to cover the wide variety of other scenarios. And as expected, both military and civil institutions were involved in developing it further. Now, the human life was threatened in almost many occasions, as I have illustrated here. So advancing along the values of self-sufficiency in the United States of America, have developed these skills and various other things as outlined in the slide. I think we believe the Sri Lankan armed forces and the police will definitely benefit by having a medical rapid deployment force. Because in view of its actual and potential threats, although we have won our war, there are threats and they are to come. So this concept was first introduced by me at the Ampara General Hospital, and the first such trainee was actually trained at the Ampara General Hospital, and we have used them in combat, and it was a quite successful mission. Now, since there are a lot of non-medical distinguished people in the audience, I'd like to talk a few things about trauma. Now, as most of my medical colleagues know, 90% of the victims in war die on the battlefield. Why? 85% of chest injuries need chest tube only, but immediately it has to be done. And 2,500 die from simple extreme hemorrhage in Vietnam War. And there's a concept called golden hour. In fact, now we call it the platinum hour, because platinum is more expensive than gold. So most die in 30 minutes of injuries if you don't do something. And there are so many penetrating injuries which requires different care from blunt trauma and so on. So you can have injury to the spine, and there are ways of handling those injuries. But if you do not understand this so-called golden hour or the platinum hour, the match is over. So the aim of the study is to introduce introduction of the concept of MRDF to Sri Lankan armed forces, police and other combat units, and the identification of knowledge, skills and basic equipment required for such a force, and organization and training of MRDF and how to do and the structure. So the methodology for doing such a thing, we have used a new technique called qualitative research. It's not a new technique, actually. It's not very much used in Sri Lanka. That's, we have interviewed several people, actually distinguished armed senior people in armed forces and in various military troops and our own colleagues. And they have done some web searches as well. So in the discussion, so what is actually MRDF? Everybody knows what RDF is. So it is simply a military medical unit with advanced emergency medical training and advanced military training. So it's basically a combat and survival. And they are independent, they should have an independent command on communications, on logistics and transport system. So it's basically a self-sufficient man who can handle combat, war, as well as the acute medical emergencies, especially life-threatening emergencies. So the role of MRDF is in all these areas. In wars, low-intensity conflicts, hostage rescue situations, civil rights, VVIP and VIP protection. I'll come to that later on, and chemical, radiological, I have listed all those things. When it comes to VVIP and VIP protection, it comes to my mind, before coming to Karapiti, I was the physician at Matara General Hospital. Honorable Mr. Mahinda Vijayasekara, when he was actually injured by the bomb blast, it took more than half an hour to be brought to the hospital. There was an ambulance by the side, but this ambulance was equipped with very basic, simple oxygen only. And the person who escorted the ambulance didn't have any emergency medicine training. We didn't have emergency medicine curriculum or any program at that time. Luckily, we have recently started. I am a board member. And then we knew how difficult for us to resuscitate him. If we had had a team like this, it would not have happened. So I recommend, actually, later on I'll come to this, I recommend that every VVIP or VIP squad must have a MRDF. So what are the types of MRDF? We can have a single member attached to a small specialized unit, military units operating in extreme high-risk situation, so-called hot zones, regular units on call, immediately deployable, like what I mentioned earlier. And then we can have a small team, which comprises 4 to 8 people, which can be deployed again immediately. And we can have a larger team, including so many paramedics, and with other emergency physicians and so on, who can even start a small hospital even in the field hospital. So what are the knowledge and the skills required actually? The knowledge actually, the basic qualification should be, for an ideal person will be MBBS with some experience in surgery. That's to go to the higher level I have mentioned here. And then the nursing degree, diploma, and anybody who is having a basic medical knowledge, paramedical people, anybody can come. So what is the skill mix? Obviously, you know, my medical colleagues will know this, basic life support and advanced life support, and how to look after the airway, how to look after the breathing, how to look after the circulation. The key factors in survival in an injury. So all those things are there, and basic things, splinting, hemostasis, wound management. And I have put something important at the bottom, that's ability to use point-of-care testing, such as pulse oximetry, that's common thing, but sonography in life-saving. The next century stethoscope is going to be, next century, not the next decade stethoscope is going to be not the stethoscope we are wearing, but the portable ultrasound, which will give some on-site idea as to what's happening inside the body. So we are going to, if we are going to develop MRDF team, we are going to train them in all these basic skills. So training, it's a nurse to doctor and becomes a soldier. A soldier becomes a nurse or a doctor. So this is actually under the new specialty which is coming in Sri Lanka as accident and emergency medicine. And then somebody might ask whether there are training centers available. Yes, of course. This new center where I'm working at the moment at Karapitia, it's a brand new center. And then Action Service Colombo, and there are a couple of other centers yet to come. One at Betiklo, one at Hambantota, and so on. So, MRDF member must understand all these points: chemical munition and deployment techniques, distraction devices and effects, and booby traps, unconventional weapons. We must have an idea about as to all these things. Weapon systems and management. I know this, most of my military colleagues might know. I need not tell all these things in detail. And of course the team concept. So training, 360-degree protection, invisible deployment, noise discipline, these are all military stuff I'm talking. So equipment. I think I'm quite sure that you may have seen people like this. This from US Army. So they have their body armor and they have various kits around their waist. So we'll see what is inside the kits. So these are the things. Ambu bag, airway kit. You know what ambu bag is? When a person can't breathe, we just put a tube and then bag the person, right? And then the intravenous cannula, trauma supplies, chest tubes, surgical kits. All these things are there. Rather than hand grenades, right? We are having all these things in